Okay, so welcome. Good afternoon. I'm Alena Skalova, and we'll start today with the 3 cases of head and neck pathology. The first one is a consult case coming from Slovakia. This was a resistance or tumor in submandibular gland or submandibular area that was quite well circumscribed, and there is even some lymphoid margin, lymphoid capsule, if you want to. So from clinical point of view, it was sent as a submandibular lymph node or submandibular tumor of submandibular gland. 57-year-old woman. The pathologist, referring pathologist, sent it as tumor, epithelial neoplasia, that they are not very certain how to classify. The section is not extremely wonderful, but I believe that you can see that the tumor is multilobulated, has a lot of myxoid stroma and some myxoid transformation and fibrostroma, that septa which divide the tumor into the nodules. The cells, if we use high magnification, are of one type. They make isolated groups or small groups in this myxoid stroma, or some kind of trabecular growth pattern, and even high magnification, if we can do it, show irregular nuclei and eosinophilic cytoplasm. In immunoprofile of this or immunohistochemical examination show that it's really not soft tissue tumor, but epithelial neoplasia. There was a cytokeratins positive. Here you can see cytokeratin. To start somehow, cytokeratin AE1, AE3. So the tumors are really positive. The other staining was CK7, and then we tried to stain CK20 and CDX2, which was negative. So the tumor was AE1, AE3 positive, CK7 positive, SOX10 positive, S100 positive, and CK5, 6 positive. So we have most likely tumor somehow of salivary gland origin. So that's what was the immunoprofile. And immunoprofile, and together with the H&E, the general structure, this kind of myxoid transformation, multilobulated growth pattern. This is the growth pattern which is quite suggestive, not typical, but quite suggestive for myoepithelial carcinoma low grade. So we tried to provide some kind of confirmation or evidence, and I did the staining for plaque 1 is not very beautiful. There is some pre-analytic damage to the tissue, but looking at some places, I made the circle there. You can see that there is a positive staining for plaque 1, at least in majority of the cells. Yeah, high magnification as well. Okay, fish confirmed plaque 1 rearrangement, and we were not successful in NGS finding any fusion because of damaged tissue. But final diagnosis is low-grade myoepithelial carcinoma with plaque 1 rearrangement, and the only problem with this case is to be sure if it's a lymph node metastasis of primary myopathial carcinoma in some gland, but not really possible to solve the problem because there was in a consulted material there was no salivary gland tissue. Actually, it could be metastasis in lymph node, but we do not know. But what we know is that it's low grade. It's low grade myopathial carcinoma. Well, so that's one case. The other case is easier or shorter, but rare and very interesting. I hope we have another salivary gland tumor. This is a parotid gland. Now we are sure that it's parotid gland, and there is a multinodular lesion which is composed of several nodules, but the dominant nodule is well circumscribed, and I will show you the histology in high magnification. So you can see that it's the tumor is composed of ductal structures. Some ducts are yes, of course, it's positive. So there was a proposal, IDH mutation. In this case, there was a IDH2 gene mutation. So diagnosis is straightforward. But before telling you, I would like to attract your attention to the fact that it's composed of solidness and tubular structures which are monophasic, monolayered. There is no myopathial layer. So the diagnosis is not intercalated duct, but striated duct adenoma. And it's a nice case because this is possible to see also these hyperplastic nodules. So it's, if you have multiple foci, maybe hyperplasia, but the dominant nodule is adenoma. So striated duct adenoma with IDH mutation, and this is quite IDH, yes, GT. There is mutation of this gene. So that's the second case, and the last one is a quite recent consult case, which was also sent from Slovakia, and it's a tumor of an older woman, about 60-year-old woman, tumor of the parotid gland, and here we have one of the slides. There were 4 blocks. One of the slides is the best one is this. So you can see that there is epithelial infiltration within a very desmoplastic stroma. High magnification may show a little bit details of this epithelial component. So you can see that it's quite solid, but there are like 2 cell types if you want to see it, but not really here. The material is quite damaged, and so I'm not capable to show you many more details. Maybe here with some in the central part there is a eosinophilic foci within the basaloid. Yeah?
Maybe even sarcomatic
Component.
I don't know.
Okay. So, what about the immuno profile? These are P63 and P40 positive. There is negative staining for S100. Proliferative activity is very high. More than 50% of cells are positive. And what else? We have CK7 somewhere, not in all, and many other markers were negative. NUT was negative, LEF1 was negative, SOX10, androgen receptors, TTF1, P16, and NAPSIN-A negative. So from these negative stainings, you can calculate that we considered possibility of metastasis from the lung primary cancer, but then it was sent for molecular testing, and it arrived today with the result fusion Y. How do you pronounce it? YAP1 mammal 2. YAP1 mammal 2. So YAP. Yep, mammal 2. And maybe you can now show the paper which I prepared. So this is exactly what. How can I move? Nahoře.
Tak se žaluje, co?
Jo. Kolečkem. Aha. Jo. I have to learn it. So here we are. Maybe I can do it like this to show you better. I believe that it's quite similar to our case, at least this picture. And this paper, which I'm showing you, is the first and the only one case report written by Abbas Akaimi and colleagues as YAP1 mammal 2 rearranged poroid squamous cell carcinoma, primary presenting as a parotid gland tumor, which is nice.
Malignant porocarcinoma.
Squamoid porocarcinoma or malignant porocarcinoma.
It's quite specific
for skin.
YAP1, NUTM1, and YAP1 mammal 2. These two fusions are specific for.
But I have never seen it as a primary tumor of parotid gland, so I'm done with my cases.
So now I will show you some central nervous system cases. The first one is quite easy and typical, but what I want to discuss is something about this tumor type. So you see, it's a recurrent meningioma. So histologically, already this tumor shows some atypical features. Okay, it shows so-called sheet-like or diffuse growth pattern. So it's not that whorled or nested growth. Moreover, it has quite prominent nucleoli. So at least two features of so-called soft criteria, which are used to distinguish between grade 1 and grade 2 meningiomas are present. Otherwise, not very prominent mitotic activity was present, no necrosis was present, no small cell change was present. So we had only maybe 2 or 3 criteria. But what is interesting here, you already see some fatty tissue. It's not metaplasia, it's growing outside the skull, okay? But it's a recurrent tumor. Maybe there was only some flap without complete reconstruction of the skull after the first operation. Okay, so meningioma, recurrent one, something between grade 1 and grade 2. And możesz, Patryk, and now I will show you a paper, which is, I believe, still in press. So it's another recommendation from this See Impact Now clarification on molecular risk parameters and recommendation for WHO grading of meningiomas. So there are some advances in molecular genetics, and there were many attempts in the past to more reliable stratify the risk of meningioma patients. Meningioma is the most frequent primary CNS tumor, so it's quite a problem. So the burden for healthcare is really big. And now we've got more precise criteria how to distinguish between grade 1, grade 2, and grade 3. And okay, the paper is still in press, so it's not very nice PDF, but there is a scheme, not very nice. I redraw the algorithm. So what we already knew that and what was recommended in the 2021 WHO classification was that we should examine probably all grade 2 meningiomas for the presence of CDKN A or B, homozygous deletion, and or p-tert mutations. And when these are present, regardless the morphology of meningioma is, it should be classified as grade 3 tumor. There is no reason to do molecular genetics for already morphologically grade 3 tumors. They look malignant, they behave malignant, but we still may have grade 1 meningiomas looking completely benign, which may have these, but the frequency of these is very, very low, 1 to 5% maybe. So already we do not do these genetics for morphologically grade 1, but what we can do is P16 staining or MTAP staining. The loss of staining is indicative of homozygous deletion of P16 or CDKN locus. And what we know that meningiomas with loss of 3-methylated form of histone H3 protein also may have worse prognosis and are more frequently recurrent. What is completely new? These are additional scenarios where additional molecular testing of meningiomas might be useful. So this is probably our case, something between grade 1 and grade 2. So you have 3 mitosis, not 4, or 2, not 3 or 4 or 5 soft criteria for grade 2 meningioma. Brain invasive but otherwise benign meningioma. In the previous classifications, these were classified as grade 2 tumors, but it's not true by using these molecular supporting findings. Grade 1 with unexpectedly rapid growth on serial imaging or recurrence, and grade 2 to confirm and distinguish from grade 1 or grade 3. And we should perform molecular genetics for these variant morphology meningiomas, including SMARCE1 gene, for example, for clear cell meningioma, or BAB1 for rhabdoid meningioma, etc. So now we use these chromosomal arm changes analyses. If you've got isolated 22q loss without other losses, it's molecularly low risk, or you can use methylation profiling, and it fits to low risk category and has got grade 1 morphology. All of this molecular stuff is confirmatory of grade 1 tumor, and this holds true also for brain invasive but otherwise benign meningiomas without other high-risk molecular features. So if you've got brain invasive meningioma and it is molecularly low grade, it should be classified as grade 1, not grade 2. Otherwise, it should be classified as grade 2. So you confirm brain invasive meningioma by molecular genetics, whether it's grade 1 or grade 2. And if you've got combined loss 1p and 22q, it's grade 2. And in addition, if it shows more than 2 of other losses, it's already molecular high risk. And if it's grade 1 by morphology, you should comment on it. There is no recommendation to change the grade, but you should comment on it. It's morphologically grade 1, but with features of grade of higher grade meningioma and probably at higher risk. And if it's grade 2 already by morphology, it's confirmation of grade 2 grade. So this is what we started doing maybe 2 or 3 weeks ago here at Baptist Club. So if I'm going back to our case showed a loss of 1p and 22q, and 3 other chromosomal changes were found, but these were not relevant. Only chromosome 6 was lost, but not any one of these. So it's confirmed it's genetically grade 2 because it shows combined loss of 1p and 22q. So this is for meningioma case update on molecular classifications of meningiomas. My second case is a brain tumor in an older gentleman with previous diagnosis of urothelial carcinoma. And the case was sent with a question whether it's a primary tumor or it's metastasis of urothelial carcinoma. So in these parts, you can see this highly malignant looking, little bit epithelial looking tumor. Could it be metastatic? Yes, in this morphology, certainly. And the case was stained, of course, with cytokeratins, and there was a little bit of cytokeratin cocktail positivity in these parts. But there is a word of caution about cytokeratin staining in brain tumors because there is cross-reactivity between glial fibrillary acidic protein GFAP and cytokeratin cocktails. So you should be very cautious if you've got cytokeratin staining in brain tumor. Okay, there is false positivity caused by cross-reactivity between these two types of intermediate filaments. But there were other parts in these tumors and with this palisading pattern, and this, in my eyes, looks more glial. Okay, and maybe in other parts some bizarre morphology. So I have performed some molecular investigation, and there was presence of promoter of third gene. So it was not helpful, okay, because p-third mutations are the most frequent genetic alterations in urothelial carcinoma, and one of the most frequent in glioblastoma. But and maybe there are some more parts, more spindle cell looking. So how to solve the case? This is OLIG2 staining, which is not oligodendroglial but general glial marker, and it's positive in a proportion of tumor cells. In these more spindle cell or sarcomatoid parts, it's almost completely negative, which is very typical. You have loss of GFAP or OLIG2 staining in sarcomatoid parts and retained staining in more well-differentiated parts of gliomas or gliosarcoma. So in my eyes, this is glioblastoma, IDH wild type, not the metastatic urothelial carcinoma. My third brain case is very interesting. This is again consult case sent for methylation profiling, and this is a case of 45-year-old female with quite a long clinical history, maybe 15 or more years ago. She was operated, and we don't know the correct. I don't know the diagnosis, the original diagnosis. But in this low magnification, we can see something which is a little bit piloid looking, maybe with this biphasic architecture with spindle cells, some microcystic spaces, and the cytomorphology of the tumor, it's quite cellular, not very high grade, but not low grade as well. So it's something between. There are some interesting, maybe in the middle you see there were eosinophilic EGBs, eosinophilic globular bodies present. No real Rosenthal fibers found. The proliferation activity was maybe EGB, the center here. So it's something piloid looking, and methylation profiling came back with the diagnosis of high-grade astrocytoma with piloid features. So it's one of the two entities in the current WHO classifications, classification of CNS tumors, for which methylation profiling is the only type of molecular investigation you can do, and you are not able to do the diagnosis without methylation profiling. These tumors, in most cases, in spite of its name, high-grade astrocytoma with piloid features, most of them show low-grade morphology and may be confused with pilocytic astrocytoma or with so-called anaplastic pilocytic astrocytoma, but their clinical behavior is much more aggressive, and it's almost like glioblastoma IDH wild type. So it's very aggressive tumor type. This particular patient is lucky. She's having a tumor for many years. So even this type of nuclei you may have in pilocytic astrocytoma with multiple nuclei. So it's not indicative of high-grade malignancy. And you can see these hyalinized vessels, which are very typical for pilocytic astrocytoma. So there are many features which make you or lead you to not correct diagnosis of pilocytic astrocytoma. So you have to be careful with piloid-looking tumors in adult patient, and probably do methylation profiling for all of these cases. Okay, and my next case, it's very nice biopsy. It's a young male patient, and he's got a lesion around his anus, and clinically was suspicious for something wrong. And so this is a case from Martin Dušek, and he showed these slides to several of colleagues, and some of them thought that it may be well-differentiated carcinoma, okay? But we've got very young male patient. And, okay, I will show you cytokeratin staining. So this even more shows you how pronounced epithelial proliferation it is, and in fact it may be quite suspicious for invasive carcinoma, very well differentiated, but the epithelium looks quite innocuous, blunt, not very malignant, okay, but still could be very well differentiated. And if we look at the very high magnification, we see this very dense lymphoplasmacytic infiltration with plump endothelial cells in these capillaries, and these should lead you to staining or doing molecular morphology. Yes, and I already hear from the audience here, we have performed immunohistochemistry. So this is Treponema pallidum IHC, and the molecular studies came back positive as well. So it's syphilis or condyloma latum with this pronounced epithelial proliferation, which if it's cut not perpendicularly, may lead you to erroneous diagnosis of well-differentiated carcinoma. So always be careful and think about syphilis, because it's not that uncommon to see cases still today. In fact, it's epidemic in Europe and rest of the world. Yeah. I saw probably last year we saw a case of ulcer on the tongue, and we performed molecular testing, and we proved that it was ulcer caused by syphilis. So I will show you silver staining, which is positive, but you will not find that nice tertiose spirochete like in textbook, probably because the bacteria are degenerated and fragmented. So based on these on this silver staining, I will not be able to do diagnosis. So immunohistochemistry is very, very good to do, and you can do molecular testing as well. So condyloma latum. And my last two cases are head and neck pathology again. So this is a small biopsy from palatine tonsil, suspicious clinically for tumor. And we already had, probably I presented the case here a few weeks ago. The lady had big cystic lymph nodes on the neck, and we diagnosed metastatic HPV positive squamous cell carcinoma. And if you look in very high magnification on this tonsil, you can see this tumorous infiltration of non-keratinizing squamous cell carcinoma. Okay, so if you do only very low magnification, you can easily miss. You can tell it's only lymphoid tissue there, but it's not. It's this non-keratinizing squamous cell carcinoma. This is P4T staining. So all of this solid-looking tissue, it's not a lymphoid tissue, it's epithelial. This is P16 staining, which confirms it's HPV-associated oropharyngeal squamous cell carcinoma. It's not graded because in spite having this undifferentiated basaloid morphology, it's in fact well differentiated and shows a very good prognosis, even in cases which are metastatic. So HPV-associated carcinoma. And the same day, probably it was the next biopsy I had, was this again a biopsy from tonsil with the suspicion of tumor, and I almost missed the case because from very low magnification you cannot see really, but it's there. It's less than 1 millimeter. It's a little bit different. The tumor cells have more cytoplasm, maybe with a little bit of keratinization here, so with partially keratinizing. And again,
there doesn't exist diagnosis inside the tonsillar carcinoma because tonsil does not have basal membranes.
Yeah. So this is P16 staining again. Here and here you've got this very minute discrete infiltration of this P16 HPV associated oropharyngeal carcinoma. And as Michal said, there is no category of in situ lesion for this. All of these tumors, even when looking as something like in situ, should be considered to be already invasive. And again, it's not graded, it's considered to be very well differentiated tumor with very good prognosis, unless the patient has other risk factors, because smoking, for example, alters the prognosis of HPV associated oropharyngeal carcinoma. So that's it from my side.
Okay, it's Michael Jr. here. We will start with something easy. This is a TrueCut biopsy from a tumor located in the pelvis. The patient was an 85-year-old female, and she had a hysterectomy and appendectomy some 25 years ago. So pelvic tumor, old lady, small biopsy, and this is what we see. Not much so far. On this magnification, you can already appreciate that this is mostly quite uniform population of ovoid spindle cells. There was basically no mitotic activity and very little atypia. So not much more to say from this. I think no necrosis, so no really high-grade malignant features, but definitely this can still be some low-grade malignancy. It can also be benign. That's the problem with soft tissue or mesenchymal tumors, that unless you know the correct diagnosis, unless you can accurately classify the lesion, it's hard to predict the behavior. But in any case, what we know, this is a pelvic tumor. Whenever you have a tumor in the pelvis or retroperitoneum and it's composed of spindle cells, first thing you should rule out is dedifferentiated liposarcoma. So this was MDM2 negative by immunohistochemistry. So that's most likely not dedifferentiated liposarcoma. Another common spindle cell tumor in this area would be leiomyosarcoma. Although this is not very atypical, you can have very well differentiated leiomyosarcoma. The morphology is not perfect, but okay, let's still perform the smooth muscle markers, which are somewhere in here. Okay. Smooth muscle actin is here. It's very non-specific, but very sensitive smooth muscle marker. So there is some positivity, but mostly in the vessels. Here is H. caldesmon, which is the best smooth muscle marker if you have the right clone. And the tumor is partially positive, but for a well-differentiated leiomyosarcoma, this is not perfect. Then we have desmin, which is entirely negative. So, although by morphology, I can imagine this could be some weird well-differentiated leiomyosarcoma, but IHC is completely not supportive of it. And really, the morphology is not very good for it either. There are not these really long, cigar-shaped nuclei, not so much eosinophilic cytoplasm, and immunoprofile doesn't fit. Well, the third possibility after D. diff liposarcoma and leiomyosarcoma, the third possibility, most common possibility of a spindle cell tumor in an adult in the retroperitoneum is GIST. So you should rule out this possibility. You can do CD34 as some basic marker, which was negative, but there are quite many cases of GIST which are negative. I think it's like 10%. So it's good to add other markers like CD117, which was strongly diffusely positive. Basically all tumor cells, and probably the most sensitive and best marker overall is DOG1, which is this here. And although it's not diffusely strongly positive, it's patchy, moderately positive. I think this is good enough. With combination with CD117, this is and morphology, this is good enough for me to call it gastrointestinal stromal tumor. Of course, you don't know where is it primarily located. You don't know the size, so you cannot say anything about the risk. You cannot do the risk prediction score. So just say GIST and let them figure it out. Okay, next case. This was a 70-year-old female, tumor around her elbow. And this was this oval, sharply circumscribed, again, spindle cell tumor. It looks like they basically shelled it out of the soft tissues. And this is Tomáš, this is from you. You brought it. And so you can see quite hypocellular spindle cell lesion. And on higher power, although it's a spindle cell lesion, you can still maybe kind of feel that the cells are not identical. Some are long, thin, spindle-shaped, such as those, wavy, such as this one here. Others are spindled, but not so wavy and much more plump, such as this one. But generally it looks very bland, very benign, and it has kind of like this neurogenic look. So you can think in the realm of benign neurogenic tumors, neurofibroma, schwannoma, perineurioma. And for those we have, of course, excellent markers. So you can do your basic IHC panel. This is S100 protein, which is diffusely positive, but if you zoom in, you can hopefully see that there are many cells, and especially those that were thin, long, and wavy, which were negative, and most of the plump spindle cells are positive. So it's good to add also some perineurial markers. EMA is quite sensitive, quite a relatively specific perineurial marker, but it often fails to highlight most of the cells. It highlights only a small subset, and often quite weakly. It's quite weakly positive, so you got to go on higher power. But in any case, in some areas you can see quite significant positivity in the thin, wavy, long spindle cells, which seems to represent like a perineurial differentiation. This area is very good, very illustrative. So it seems the second subset of spindle cells is basically perineurial cells. The most sensitive but not very specific marker is GLUD1. So this is GLUD1 marker. Again, these long, wavy, thin spindle cells with they have these perineurial cytoplasmic processes, which are also highlighted by these markers. So you can see perineurial component of the tumor. So this is hybrid schwannoma perineurioma, benign hybrid neurogenic tumor. I'm just an absentee. Okay, and this is the first description by Hornig and Fletcher.
We are not trying either of us. We published 2 years before we published.
Yeah, but that was something else. Also, the fingers. That's a different subset. This is 15 years ago.
Not 15. 2 years before this paper.
You're talking about different tumors on the fingers, and this is different tumor.
Oh, okay.
This is there's a subset of schwannomas, perineuromas, or so-called, that occur on the fingers typically, and those seem to be something a little bit different. But most of these hybrid schwannomas, perineuromas are in soft tissue proper, and if you look at some of these pictures, you see virtually the same. So bland tumor, quite hypocellular, and a mixture of plump, large schwannomatous cells with long, thin perineural cells. And why I'm showing this paper is because they perform this beautiful double staining. So the red marker is S100 protein, and the brown is EMA. So we can see that the different populations stain differently. And a few years ago, again, Dr. Hornig and Dixon found out that these hybrid tumors, most of them harbor VGLL3 fusions. So they are molecularly completely different from schwannomas, which are typically NF2 mutated, and also from perineuromas, where the molecular is mostly unknown. There are NF1 mutations in few. There are TRAF7 mutations in a subset. But these hybrid schwannomas, perineuromas typically have CHD7, VGL3, and some other fusions. So VGL3 fusions can help you if you need to confirm your assumption. Okay, so completely benign tumors. Next case, this was a case from routine practice, vaginal polyp, 70-year-old lady. The tumor was some 5 millimeters in diameter. And we see here fragments of the squamous epithelium vaginal with a lot of glycogen in it, and underneath you can see these nests again of squamous epithelium. The nests seem to be directly below the superficial mucosa, and there is one other component besides the stroma, the spindle cell stroma, which is probably normal stroma in this area. There are also these tubules, basically bilayered with outer and inner layer. So this is called tubule squamous polyp of vagina. Typically, it's supposed to be in the upper third portion of vagina. Here, in this case, we don't know the exact location, and they are typically in postmenopausal women. And while the squamous epithelium is just ordinary squamous epithelium, the glandular structures typically stain for prostatic markers. This is NKX 3.1. PSA would be also positive in most cases, so these seem to be basically prostatic glands, and there is like an analog of prostatic glands in female genital tract, at least in some ladies, which is supposed to, which is called skin glands. They are typically around the external orifice of urethra, but there might be the possibility that they are ectopic and can be also in the cervix or other portions of vagina. So the theory about how the tubulosquamous polyp arises is either from some mesonephric remnants, or, which probably is more likely, from these ectopic skin glands, which are metaplastic. So the squamous epithelium might be metaplastic, but due to the estrogenic stimulation, but nobody knows for sure.
Differentiation always look like this, like mosaic-like pavement. Yeah? It's always mosaic-like pavement of squamous cells. Yeah? And very often these squamous epithelium have inclusions of prostatic glands. I'm sure it will be here as well.
Yeah, I tried to look closely, but I didn't find anything persuasive.
Sure
Maybe,
I had one in my slide.
but you can see it's closely, intimately associated with the squamous epithelium. It's very close to it, so might be arising from it. So tubulosquamous polyp. This is the seminal paper, 17 years ago, tubulosquamous polyp. Just for your reference, it will be online if you want. There is not much to show because it seems the cases just look identical one to another. So I think this is, here you can see the admixture of the glands with squamous epithelium. Okay. And last case, let me just. Okay, last case is the craziest. This was a consultation. Was adult male tumor somewhere on the calf. I don't know the size, but it's probably pretty big. And the submitting pathologists, they considered the diagnosis of synovial sarcoma, and therefore the orthopedic surgeons were considering exarticulation, amputation of the leg. So we had these tiny fragments which show something partially solid, partially cystic. And I must say that I had just no idea what I'm looking at, but I definitely didn't think I'm looking at synovial sarcoma. And I even, like before I started doing molecular, I wrote them a quick message that I don't think this is high-grade sarcoma, that this is either benign or low-grade malignant. And I was just hoping that they will not do the amputation before we get the molecular. So there was no mitotic activity, anything, not really atypia, just increased cellularity, ovoid to spindle cells, this sclerotic hyalinized stroma and perivascular hyalinization. So there were many possibilities, but the immunohistochemistry basically showed only focal. No, not all the basic markers, S100 protein, cytokeratins, desmin, everything was completely negative. Only thing that was a little bit positive was this. This is STAT6. So there was some focal nuclear expression, which is, and CD34 was negative. So although the morphology would be good for solitary fibrous tumor, this focal STAT6 expression would be unusual. Solitary fibrous tumors are typically diffusely positive, but still we could, entertain the idea that this was some damaged tissue, so not perfect reactivity. So SFT was definitely on the table, but for me, this focal STAT6 positivity would be more in keeping with GLI1 amplified tumors, which the GLI1 gene, which defines these tumors, is very close to STAT6, and when it is amplified, there is often amplification of STAT6 as well, leading to this focal positivity. So I was suggesting this is either benign or low-grade malignant tumor, potentially GLI1 or SFT tumor. But when the molecular came back, I had to change my idea. So this is a recently described and still evolving group of mesenchymal tumors. I'm sure Alena Skalova and other head and neck people know this fusion because it has been described in ectomesenchymal chondromyxoid tumors of the tongue. These tumors typically occur in the tongue or rarely elsewhere in the oral cavity. But in recent years, there have been cases with the same fusion described in other areas. And some of those were morphologically a little bit similar to ectomesenchymal chondromyxoid tumors, but others were completely different. So I don't know, 2 years ago, 2 years ago, Abbas, Agaime, and others collected 5 of these cases, and together summarized the literature before. So altogether 10 cases were reviewed and discussed in this paper. And basically what they found out is that the morphology is very heterogeneous. Some cases look or have a lot of chondroid matrix, such as those here, and so that would be one subgroup, some mesenchymal tumors with chondroid differentiation and quite bland morphology, and the other subgroup, which is illustrated here and which was also illustrated in our case, was kind of hypercellular spindle cell tumors, some of them with perineurial differentiation by immunohistochemistry, but it was not our case, but our case looked very similar to this.
Our case was compatible with tongue tumor.
Yeah, there were some morphological features with the tongue tumors, which is also actually described here in this part, like myxoid areas, solid areas, spindle cells, cystic spaces.
In our time, it was called myopicema of the tongue, which is compatible with that.
Yeah, but unfortunately, the morphology seems to be very heterogeneous. I don't think it's possible to recognize it by morphology. There is no immunohistochemical marker. Many cases are S100 positive, but not all. Some cases have perineurial differentiation. So this case is just to illustrate how crazy soft tissue pathology can be, and that without molecular, sometimes you can do a confident diagnosis, but sometimes with molecular you can assure the clinicians not to do amputation when it's not necessary. So, okay, this was the last case, and because there are Christmas coming up and all the holidays and etc., we will meet in 1 month, 7th of January. So thank you for your attention.